Hello, and welcome to our Eye-to-Eye session in the December 2021 Eye-to-Eye conference. This is Emerging from the Pandemic, Using Data to Transform Whole Person Services and Supports for the Future. My name is Doug Golub, and I am with MediSked, and MediSked is the electronic health platform where the data and the insights that you'll look at today all came from.
I'm Matt Kaufman, CEO of StationMD.
Hi, I'm John Nash. I'm Executive Director with the ARC of North Carolina.
And MediSked, if you're not familiar with us, we founded back in 2003, have over 100 employees around the US, and we make the platforms that are used by oversight tailored plans, several tailored plans, CMAs, as they emerge, and providers supporting over 400,000 people across the US. We're a reliable partner with proven experience in adapting to rapid regulatory changes, much like what we're seeing with the tailored plan transformation here in North Carolina in 2021 and 2022. We've been working in North Carolina since 2011 and are very familiar with the different LME MCOs that have emerged and merged and continue to evolve into the tailored plan model into now December 2022 and beyond. For behavioral health, IDD, traumatic brain injury, and substance abuse and state-funded and waiver services with that new launch date of December 1st, 2022 as of the time of this conference in December 2021. This transformation dates a ways back, including starting in 2015 with the direction to move to managed care, including integrated whole person care, the standard plans that we all saw launch earlier this year in 2021, and the tailored plans that are now scheduled for December 2022. We'll be talking about some of the systems and the data as the requirements are coming together and show what these systems can do specifically around whole person supports, telehealth, and teleservices, and what they have been doing throughout the course of this public health emergency. So here we show a diagram that shows how some of these systems work both today and into the CMA and tailored plan world of the transformation that will take place over the next year and the glide path in the 5 years that follow. And so we start by identifying, of course, it could not be a presentation in 2021 without talking about COVID-19. We start by identifying that people with IDD and behavioral health are at a greater risk of having adverse outcomes from COVID-19. We identified today that teleservices have helped keep people safe, connected, and also change the future of service delivery. For the IDD population, the strongest independent risk factor for COVID-19, people were 2.5 times more likely for presenting with COVID-19. We also take a look at vaccinations today and identify several other facts that we find around people that are vaccinated versus unvaccinated and hospitalizations, and also more severe outcomes, mortality, we take a look at to see how the data and how the systems and how the telehealth tools that are available to us have saved lives and changed the way that services are provided going into the future. When it comes to telehealth and teleservices, particularly for behavioral health, mental health, and also IDD services, 43% of adults surveyed say they want to continue to use them when the pandemic is over. 59% of Americans say they would also use it for mental health services, which is a really important priority for CMS and for everyone going forward as we begin to unwind, assuming that we're done winding, begin to unwind from the public health emergency. So 1 in 3 adults say they would prefer telehealth to an in-person doctor's office visit, if it makes sense. And we have our partners from StationMD today to talk about some of the other benefits that come with that and some of the successes that are not part of the future, but part of the present. So the tailored plan transformation in North Carolina, this is a really big opportunity to build effective models for managing comprehensive needs through care management in a community-based, provider-driven model that's aimed at whole person care and driving towards better health outcomes. Individuals with significant behavioral health needs and IDD included in this tailored plan transformation, they do have more severe COVID-19 outcomes. Telehealth and teleservices have offered opportunities during the public health emergency and have transformed the possibilities for the future. And today we apply data analysis from a process that integrates supports and technology to improve individual well-being and population outcomes. We both measure and improve with the data that we look at today. So we start by having a conversation about the Community Navigator service. This is a service that lends itself really well to opportunities in telehealth. Again, not every service lends itself well to telehealth and teleservices, but this one does. And so with that, we have John Nash from the ARC of North Carolina to talk about some of the changes in this particular service during the public health emergency.
Thanks, Doug. For starters, for those of you that are not familiar with Community Navigator, it is a connecting service. It is not care management, it is not care coordination, and it's not case management, but it has elements of all those activities involved in it. And really, it's about connecting the dots, connecting people with housing and transportation, jobs, in-home services. Sometimes it may be connecting them with social services and other activities and things that they need to be address the needs of the whole person. It is, again, we've got a great diagram there that shows when you're looking at care management, it's probably about 30 to 40% of what care management is going to be doing includes what Community Navigator currently does as a service. And it definitely deals with the whole person, and it's generally a face-to-face, in-person kind of activity. Although in a pandemic, that's certainly hard to do. And part of what we've been trying to accomplish is quantify and capture when we're doing in-person, whole person kind of activities, how effective are we and what exactly is the outcome? And it's really about, in-person, whole person activities, person-centeredness is abstract. It is certainly not clear, what exactly does it mean? Well, it's different for everybody. So how do you quantify what is essentially almost unquantifiable? And that's interesting because we actually are able to capture some of that data, and that's what we've been doing. Go ahead and shoot to the next slide, please. To give you some background, in our Community Navigator service, we are talking about a little over 2,600 people, almost 2,700, most of whom are in some type of home and community-based setting. So this is in-person, person-centered, community-based activities for the most part. And for the rest of it, the average age is 28. The division between male and female is 66 to 34. And it's mirrors pretty much what the national population looks like. Go ahead and next slide, please. Doug, I'm going to let you go ahead and talk about some of the data that we've collected nationally, and you're better at this.
All right, thanks. So at the ARC of North Carolina, the community navigators that provide this service, as they're logging their notes and their activities, they're also logging what kind of a service was this. Was this a phone call? Was this over Zoom or Teams or FaceTime? Was it face-to-face in person? And they've been doing this for years. And we take a look in 2018 and 2019, and the gold bar up on top, these are virtual services. We've combined telephone calls with video calls. We could split them out, but obviously there were a lot more telephone calls going on in 2018 and 2019, and a lot more video calls started happening as the public health emergency emerged. But we've always seen for a service like Community Navigator, the majority of the services, 56%, could be done virtually, leading up to COVID-19's emergence in 2020, and 44% have been in person. And so this is sort of setting the baseline. The service was growing, but the service was growing for both in-person and virtual services leading up to the end of 2019. Something happened at the end of 2019, the public health emergency, we're all familiar. Here in North Carolina, the peak, when we look at hospitalizations due to COVID-19, the peak was in February of 2021. And while it's peaking again, we hope to not reach those levels. And we hope that this is the last of the peaks. We don't know what the future holds, but we know what has happened in the last 2 years. And we take a look at that and say, what does that do to services like, for example, Community Navigator? And here we see exactly what happens in March of 2020. There was a steep drop-off over these 3 months of the beginning of the pandemic to in-person services, and a steep pickup of virtual services as lockdowns and some of the other safety precautions came to be. And they've sort of stayed that way. There was an aberration around the holidays here, but that was also around the time of the greatest peak here in North Carolina. So life was very different in the winter of 2020 into 2021, and we're hoping for a very different set of circumstances this coming winter of 2021 into 2022. But whereas prior to the public health emergency, about 44% of services were in person, now we're averaging about 13% of services in person, which is not terribly surprising, but it actually helps to look at the data itself to see how significant this has been. And with that, we say, okay, we understand that we're delivering a lot of these services virtually now that used to be in person, right? We have to ask ourselves before we fetch our keys to go out and see somebody, could it be a phone call? Does it have to be? And there are times where the answer to that is yes. But overall, what does that mean for outcomes? What about the quality of these services and what they're doing back to their goals for the people that are supported? Clearly these services are taking place virtually now. Are they working? And one of the ways to measure that, there's a lot of debate and discussion about, well, how do you tell? How can you? Is it too early? Is the book still being written? One of the ways to look at that is by taking a look at the national leaders, and that's CQL, the Council of Quality and Leadership. This is some CQL national data. Next, we'll take a look at the ARC of North Carolina, but some national data that CQL has published that help identify personal outcome measures in 21 different domain areas about whether outcomes are present or supports are present. And what they're finding is consistent. And what they're finding nationally is that when it comes to almost the Maslow's needs hierarchy of sort of health, welfare, and safety at the bottom, we're finding that people, by and large, throughout this public health emergency, have had those, especially people supported by waiver providers, their health, welfare, and safety needs met. But when you take a look up the hierarchy of whole person and talk about intimate relationships, participation in the community, interactions, friends, you're finding that these are slipping significantly. People choosing their own goals, having freedom, having flexibility, those are surging. And so it's been a bit of a mixed bag for the public health emergency. Some things have really improved, and some things, as we unwind from the public health emergency, we had a lot of work to do before. We'll have even more work to do now when it comes to supporting people to live their best lives in the community as integrated as possible with friendships and relationships. We're finding that those items have not progressed as well during the public health emergency. And with that, we're going to take a look at the ARC of North Carolina and their POMS results during this period of time to see specifically how is this working.
Well, thanks, Doug. So looking at the ARC of North Carolina's data, and some of this was a little bit of a revelation to me, and we look at these things, but I had never seen it quite in this format until we sat down and started working through some of these issues here for this presentation. And it's interesting to see the things that we saw that dipped are things that everybody had decreases in. Well, our ability to have intimate relationships, our interactions, our social activities, the participation, the things that normally everybody is hopefully having good experiences with, all those declined for people with IDD at the ARC that we were serving, as well as everybody in the world at that point. So, I mean, there's no revelation there. What was a revelation is in the things that increased and increased significantly. People felt more respected. And again, this is from the POMS information. So these are people with IDD that are being served and meeting and part of the ARC of North Carolina's group of individuals that we provide services and supports for. They were safer. They felt like they could use their environment around them, choosing their goals, which is really interesting. They got to choose what they wanted and their realization of those goals. And for what it's worth, they felt like their health has improved. I mean, and these things, as you assess them, you know, in the middle of a pretty negative world environment that we're in, are remarkable. And part of this, I'm wondering, as we've looked at this, is this the result of necessity is the mother of invention, that the environment changed and people with IDD adapted? And sometimes I wonder, do we underestimate what people, anybody, much less people with IDD, are capable of adapting to? And while it hasn't been pleasant, we have seen some adjustments and people have adapted to a pretty negative environment in some interesting ways. And that's my takeaway from this. What is probably more interesting to me is now we're beginning to correlate abstract outcomes and safety, respect. These are all abstract concepts, but we've been able to quantify them. And now if we can quantify it, we can begin to create plans around what do we do to improve based on what we've been doing. And the environment that we've been in for the past 2 years almost now has dictated that we change how we work. And for me, that's been really helpful, particularly as we prepare to move into a tailored plan environment where we have to do things differently. And really, we're moving away from the old approach to fee-for-service activities where everything outcomes are based on did you do this specific activity to what is the result of having done that service. And that's now the measurement of success or failure. And those results are really based on abstract outcomes. And how do we go about meeting those needs? And so what I'm seeing here in the data that I'm looking at, and if you can go ahead and advance to the next slide, what I'm seeing is that we are being successful. And again, taking a quick look at North Carolina, and this puts it into some context, 70% of our counties, of our areas that we serve, are rural. 30% are urban. And if any of you ever worked in and outside of urban and rural environments, the approaches are very different, and how we go about doing it may be very different. Go ahead and move to the next slide. This slide talks about how we approached over the last, beginning in 2018, how we've approached teleservices and telehealth from a remote perspective in urban versus rural communities, and interesting things that you would expect to see. In an urban environment, we're closer, it's easier, distances aren't quite so far, and so there is certainly a lot of telehealth going on, but it's not so much, we're still seeing a lot of in-person things. The more rural you get and the more distance there is, the ability to access services remotely, certainly they've been making use of it, and it's bridged a gap, especially in an environment where we have shortages of staffing, we have difficulties finding people in certain locations. The ability to do it remotely shortens the distance, closes the gap, and enables us to continue to do what we've been doing, which is meet the needs of other people in a pandemic. Go ahead, next slide. So how has it changed? Let's advance to the next one and talk a little bit about things that have been going on. Again, tracking beginning, our tracking goes back far further than 2018, but the annual ups and downs that we see are consistent with the beginnings of school, holidays, when people need things, when people don't need things. And then you get to March of 2020 when everything shuts down and comes to a screeching halt, and what you would normally expect to see as an increase is, by all standards, a huge drop in everything, face-to-face, every activity, everything's coming to a screeching halt. And then we began to recover. And while the recovery doesn't necessarily mirror what we were doing prior to, because we've had to change how we do business, we're still in a very heavily locked down mode. A lot of people say, I don't want you in my home unless until we know what's going on. Early on in this, we had a number of families say, we love you, we want you here, but until we know what we're dealing with, you can't come into my home because I don't know what you're doing every other hour other than when you're with us. And so in-home direct services really got more complicated. But as you can see, even with the decline in in-home services, we're still following the same patterns, just not quite as much. We're still finding ways to get the job done. Go ahead and next slide. The ARC, amongst other things, we do an awful lot of self-directed services where families themselves choose the person that's going to be in their homes providing the services, and they're in effect controlling what happens much, much more than when somebody else is the direct service provider. They're doing their own work. And it's always been a slow increase because it's a lot of responsibility. And as you can see, and if you look at March of 2020, there's a huge spike. I mean, we're not bringing outside individuals in, but we began to hire family as provider, and allowances in the K waiver allowed us to do that. And we began to see once again that number of people taking control of what's going on in their environment. And that may have something to do with some of the increases that we're seeing in terms of outcomes in the personal outcome measures, that I have more control over what happens in my world. I'm making more and more of my own decisions. Yes, it's more complicated, but on the other side, I also have more control. So there's always a give and a take there. And again, we're beginning to see that. And it's been again, in an environment where we're having a hard time finding staff in the first place, this has been a huge boon and a huge benefit to be able to plan for an environment where we can't bring people in. And again, as we move into a care management environment in the tailored plans, where there is going to be a huge demand for staffing on a variety of different areas, this, I think, becomes a much more critical data point for us to be able to track into the new environments. Next slide.
On the MediSked side, we started a program back at the beginning of the public health emergency for our own staff to stay connected to individuals and families and remember why we're here in the first place. So we started this program called Virtual Visits that allowed us and our 100 or so staff to actually meet with people face to face, advance our own telehealth strategy, and use that as a time to connect and to build relationships because our folks needed it too. And here's a quote from a family in North Carolina that we had the opportunity to meet with. For me, this is a gift of time. I get 30 minutes where her son, is occupied and happy. He and I have been locked down together since early March 2020. This quote is from 2020. They're not locked down anymore. March 2020, when we were exposed, thankfully we didn't get it. I love my son, but it's difficult to try and work all day and help him have a good day. His church group did a Zoom scavenger hunt, and it was fantastic. He was running around the house laughing as he was looking for things. It was the most joyful I have seen him in quite some time, a parent of an individual receiving services and supports. And so these were early on. Everyone else sort of figured out how to do this for services during the public health emergency, and we figured out probably 10 years worth of progress over those first 10 weeks, and they've forever changed services. So it's really important as we look at what services look like in the future. We also take a look at COVID-19 vaccinations, and we'll be looking at the Life Guardianship Program. The reason we look at the Life Guardianship Program, these are the individuals for whom the ARC of North Carolina is the guardian. We look at this because there is complete data, because the ARC of North Carolina literally is the guardian and they know exactly who's been vaccinated when and with what. That's the only reason we zoom in on this population. So there are 792 people for whom the ARC is the guardian. 47% of those people live in certified settings, group homes. 42% live in non-certified, more integrated community-based settings, and 11% live in institutional settings. The average age is 50, so we're talking about a population that is a little bit older than the national average and a little bit older than even the average for the people supported by the ARC of North Carolina. And that's important when we take a look at comorbidities and health outcomes and COVID-19, because age is absolutely a factor. And here we find that aside from having their IDD, which is a comorbidity, 60% don't have any other comorbidities. 23% have one other comorbidity that's a COVID risk factor. 12% of people have two comorbidities that are COVID risk factors. 5% have three COVID risk factor comorbidities, and 1% have four comorbidity risk factors. So the vaccination is hopefully a way to get out of this public health emergency, and we saw a huge surge back in January 2021. Of course we did. That's when that's when the vaccine became available, and the 1A and the 1B groups here in North Carolina were able to get them. We saw another increase of 46% in February, and then we saw it wane over the course of the summer, where once people were able to get it, we saw decreasing numbers of people actually getting it once access was no longer an issue. That changed in August of 2021 when the Delta variant arrived, and it was suddenly a catalyst for those people that hadn't been vaccinated going and getting the shot. And so the data here was cut off on 9/1. The numbers continued to improve, but at that time, 73% of the people, the 792 people in the guardianship program that we study today, 73% of those folks were vaccinated, compared to 55% of all North Carolinians at that time. So this population was at a higher level for the shots than the general public in the same 100 counties. One of the things that we found is that in general, for those folks that are vaccinated, it actually increases by age, and then it begins to decrease after that, even as a percentage. Back in January, February of 2021, the chart didn't look like this. First, older Americans were eligible first, so you found that older people were far more vaccinated than younger people. And what this tells us here is, over the course of time, when access was no longer an issue because there was plenty of supply, when the supply and the demand balanced out, it all sort of came out in the wash, where you would think that people that have higher risk factors and people that are older would be more vaccinated, and they were when they were the only ones that could get the shots. Once it became available to anybody and this all balanced out, that really wasn't the case anymore. In fact, age was a factor for vaccination, and on average, older folks were less likely to be vaccinated. And we saw some of the data here than younger folks. The largest group were those 50 to 59. So there are some generational components to this, and health components to this, and communication components to this. This is a complicated subject, and we're just putting the raw data out there. And many books and papers will be written on the why. But specifically, one of the things we found most interesting here is that there are risk factors that make you more susceptible to a more severe outcome from COVID-19. Specifically looked at diabetes, hypertension, obesity, COPD, and others. And of course, back at the beginning of the public health, the beginning of the access to vaccines, the beginning of 2021, we found folks that had these comorbidities were much more likely to be vaccinated. Today, when we look at the vaccinated versus unvaccinated populations, it almost is exactly the same. People with diabetes, 22% of the people with diabetes, or of the vaccinated population, 22% of diabetes. Of the unvaccinated, 21% of diabetes. Same with hypertension, 19% of the vaccinated population, 21% of the unvaccinated. It's actually worse. And so what we're finding here is, of the people that are unvaccinated, 38% of them have these comorbidities. Of the people that are vaccinated, 41% of them have these comorbidities. It's about the same. And what that tells us is people that are at a higher risk are not necessarily more likely to be vaccinated. It's not that's not what happens here. It comes out in the wash. They had access before anybody else, but over the course of time, everybody else is sort of caught up, and it's not really a differentiator when it comes to who's actually vaccinated now. And I want to introduce Matt from StationMD to talk about some of the other tools that have become, that have always been incredibly helpful and relevant, but have certainly been critical and life-saving during this time when it comes to telehealth and teleservices from StationMD.
Thanks, Doug. So again, I'm Matt Kaufman, CEO of StationMD. I'm an ER doc, and one of the things that John and Doug have touched on is really what we've learned from the pandemic, which is sometimes virtual services are aren't just a substitute, but they actually can improve things. It's not just a way to provide a service where you couldn't otherwise, but it's a way to actually provide a better service and impact quality of life, and in my and I will argue impacting healthcare in not just an adequate way, but actually a superior way. So a little background on StationMD, and what we do is we're ER docs, including me, and we were founded based on the observation of what people with IDD and other populations go through when they go to the ER, and what kind of medical care they get, and you know, where the problems exist. My main argument here is for people with IDD, telemedicine and telehealth in general can really serve as really elevate the medical care, not just be a substitute or access point, but it actually can be much better medical care if done the right way. And again, we do it this way. There are plenty of other telemedicine groups that are doing excellent jobs as well. But in my opinion, the key is to tailor the program to people with IDD if you're going to be successful. And that includes several elements that I'll get to. But first, I just want to mention what happens in the sort of status quo in the population of people with IDD when they do have a health problem. We know that they use the ER much more frequently than other folks in the general population because of medical reasons, because of regulatory reasons, and just gaps in care that exist. So folks end up going to the ER, and what happens in the ER is they see an ER doc who has not been trained in any way in addressing, communicating, understanding the social and medical challenges of this population. And there's a lot of over-testing, a lot of over-admission, and moreover, just the actual presence in the ER, a lot of waiting. So that's exposure to infection. Obviously during COVID, this is true, but it's always true. It's always been true. There's a lot of exposure to trauma and sort of scary situations. Other folks in the ER are very sick, there's yelling. ERs are not fun places. Someone with potentially sensory issues, or really anyone, can really be traumatized by this experience. And the experience itself can be destabilizing for a population that often requires stability to you know, manage their lives. And this is true for caregivers as well, and for direct care staff, for family, everybody who's exposed to the ER. So it's not, so the system that exists is not a good system for this population. That was true before COVID. COVID certainly highlighted it, and one of the silver linings is people recognize that telemedicine can be an option, not just an alternative, but in what I'm going to argue is really a superior option. Next slide, please. So what's happened over the course of the last couple of years is obvious. What we've seen an increase in our encounters, really because of an increased acceptance. But again, the realities of the system that exists without telemedicine for this population going to the ER for these avoidable purposes has always been true. So in 2019, you can see we had many fewer visits, increasing incrementally from 2020, and then of course in 2021 we have close to 25,000 visits, and those are encounters that are our program is based on a 24/7 availability with ER docs that are specially trained in this population, and that is key because number one, issues and gaps in care don't come up on a schedule. They don't come up 9 to 5. They come up anytime. So you need to be available for that, and that's true for family members, for staff. There are basic questions that need to be asked. Hey, you know, is this an issue that I need to send someone to the ER for? Where am I going to get that answer? If I'm not a medically trained person and I'm taking care of someone who has very complex needs, it's a very difficult answer to respond to. And so having an availability of just someone who understands the population, who's medically trained, that in and of itself is a huge benefit for this population. Next slide, please. So the numbers of states that we're in similarly has increased, and again, the dark blue are the folks that are utilizing our services. What we would like to see is specialized telemedicine for this population across the country, in just more attention being paid to this population, and understanding that telemedicine can be a really, really valuable resource to fill those gaps in care. I would love to see North Carolina, of course, turn blue there as well. But the important point is, look, we are understanding telemedicine for the entire population is becoming more important and an access point for care. If you design a tailored program with specially trained doctors that understand the population and bringing that doctor to that individual at the right time, you can dramatically improve their care. And I will argue, going back to Doug and John's point, dramatically improve the quality of life. And I'll mention that in a moment. Next slide, please. So just to give a sense of the diagnoses that we see for these, again, gaps in care, anything that comes up, we're seeing medication questions, medication issues, refills. I mean, one of the very basic problems that we've seen long before 2020 is someone who's on a medication and they're on Keppra, for example, for their seizure disorders, can't get a refill, and they can't get a appointment with their neurologist for another 3 weeks. Well, they're going to have a seizure if they don't take their Keppra. And guess where they end up? They end up in the ER. So they can end up in the ER after they've had a seizure, or they can end up in the ER before to get their medication refill. But I've seen for years people having seizures or ending up in the ER for these reasons. StationMD, one of the very simple things that we can do, and a specialized telemedicine group can do, is just refill those medications and gaps in care. That's about the least kind of interesting thing that we do, but it's impactful. But there are other things too that are much more sort of medically based, a fever, a rash, these issues that come up for anyone that can result in an ER visit just because there are gaps in care. You can't get into the primary care doctor within the given amount of time. And so again, the next step is that 911 call. The blue represents those folks that we were able to address the needs and treat in place. The red is those that have been transferred to the ER. Overall, we are able to very consistently treat in place and address the need about 90% of the time without transfer to the ER. The one here that is more red than others is unspecified injury to the head. So someone falls, they've hit their head, and we're concerned, and there's no way for us to rule out some sort of serious brain injury. Obviously, we're going to send those patients to the ER. But again, I think that part of the specialized approach needs to be a phone call to the ER to say, hey, this is what happened. This is what I'm concerned about. Let me help direct the care here. And that goes a long way towards preventing some of that over testing and so forth. Next slide, please. So outcomes, again, I mentioned this, that really we're able to avoid those ER transfers in the vast majority of our calls. That's very, very consistent across the board over the last several years that we've been working with people with IDD. Next slide, please. So this gets to really what Doug and John have touched on, or done more than touched on, spoken about in a really profound way, which I feel like is in some ways as meaningful or more meaningful than any of this, which is really how's it impacting the quality of life? What's the experience of the individuals themselves with another option? And I would say that it's somewhat inferable. We can infer that someone does not want to spend 7 hours in the ER waiting to be seen for a scraped knee or to get an ankle x-ray. That may not be necessary. They would probably prefer to be playing their music or playing or socializing. All of those choices and those self-directed issues. Time, how we spend our time, there's nothing more kind of germane or central to those choices. How do you want to spend your time? So right now, a lot of that time is being spent with unnecessary ER waits and even hospitalizations that are avoidable, which can really cause major disruption. So really, it comes back to how does an individual want to spend their time? And again, we're starting with some survey results. We think that there's a long way to go, and really, exploring just how big of an impact that this kind of opportunity has. But we've started this process. 93% are happy with their encounter. 96 found it technically easy. 97% thought it made seeing a doctor easier. And again, this survey was developed with icons and other nonverbal techniques to make sure that we are able to communicate and get communication from our patients as easy as possible. Next slide, please. So, look, that we recognize that, that really that the third tier of sustainability in this kind of model is making sure that it's cost neutral. In this case, in our experience, it's much better than cost neutral. It saves a lot of money. But we think we have much better medical care. We're improving people's quality of life. And now, can it be sustained with dollars? So this is an MCO case study. This is their data in New York State. It's a mutual a client of MediSked and StationMD's, and looked at 1,100 members over 10 months. It found a 13 times ROI over, again, this small population saved about $2.1 million, and the cost reduction per member was around greater than $2,000 per member per year. The total cost for our services was a fraction of that. And so, the important point here is, look, this is in terms of dollars, which is really what are required to sustain a program like this. You can easily make a case that this is really a great option for the future. Next slide, please.
All right. Thanks, Matt, and thanks, John. So to bring that all together, thank you everybody for coming to this session, and hopefully you've got some data that's helpful in thinking through what the future looks like and where we go from here. As we started with the Taylor Plan transformation in North Carolina, it is an opportunity to build effective models for using comprehensive needs and care management in a community-based, provider-driven way, aimed at whole person care and better health outcomes. That's why we're doing this. Individuals with behavioral health and IDD, certainly during this COVID-19 public health emergency, unfortunately, have seen more severe outcomes. And telehealth and teleservices have offered opportunities during the public health emergency and beyond to transform these possibilities for the future. And supporting people via teleservices is a 21st century solution to many things, including the workforce crisis. And the quality and the outcomes that we've seen are showing significant progress. So we're very pleased to have been invited here, and thank you for joining us. And with that, enjoy the rest of the Eye to Eye conference. Thank you for having us, and hopefully everybody's in person next year. Have a good day, everybody. Thank you.
Thank you.